Good day. Today I'll be doing patient assessment trauma, BSI, ensure my scene is safe. I will determine my patient's MOI or NOI at this time. I would determine if it's my only patient, if I need any additional resources, and if C-spine precaution is needed at this time. As I approach my patient, I will form a general impression, my patient's age, sex, race, the chief complaint, level of consciousness of my patient, the patient's skin color, temperature, and condition. Also, is my patient appearing to be sick or not sick, distressed or not distressed. As I approach my patient, okay, name, I would determine if my patient is alert. If not, I would try verbal stimuli or painful stimuli, or my patient, if my patient is unresponsive. I would then determine my patient's orientation if my patient is alert, asking patient's name, where are we right now, what year it is, and the event, explaining what happened. I would reconfirm my patient's chief complaint, the reason for the call. I will move on to my airway. My patient, if it is unresponsive patient, traumatic injury, and I'm unsure of C-spine, compromise, I would have somebody hold C-spine, and I would open the airway via the jaw thrust. If my patient doesn't have any suspected C-spine, I would open the airway using the head to chin lift, making sure my patient's airway is open, clear, and self-maintained. I would then go on to the breathing, put an SpO2 on my patient's finger. Depending on the reading, I would know how to administer oxygen, if I need to administer oxygen, and what device and volume to use. I would then go on to inspect the patient's chest area, exposing. I'll be looking from the nose to the diaphragm for any nasal flaring, pursed lips, any cyanosis, any tracheal deviation, jugular vein distension, accessory muscle use, BCAP-BTLS, rise and fall of the chest, symmetry and equality, the rate, and the type of volume. I will then go on to palpate my patient, looking for any BCAP-BTLS, looking for tracheal deviation, accessory muscle use, checking C-spine for any BCAP-BTLS, around the trapezium, the acromion, down the clavicle. Is a female, so I'll go to the center of the chest, looking for BCAP-BTLS. Down here, I will check my patient's rise and fall of the chest, also the rate, tidal volume. I will go up mid-axillary, along the axillary line, looking for BCAP-BTLS. I will then auscultate my patient at the 4 points, mid-clavicular on both sides, mid-axillary on both sides. Looking for anything to stabilize at this time. Then I'll reevaluate my oxygen and determine if I need to adjust oxygen if I had already given her, or if I need to give her any oxygen at this time. Next thing I will do is be going on to the circulation. I will be checking for pulse, rate, rhythm, and quality for my patient. I will then check my patient's skin, look at the color, the temperature of my patient's skin, and the condition. Is she dry or diaphoretic? I will then go on to bleeding, looking for any obvious bleeds. If my patient is alert, I will be asking any blood in the vomitus, the stool, or the urine, or you bleeding from anywhere. I would go on to check the voids of my patient to make sure there is no blood anywhere. At this time, I'll determine the status of my patient using the Cup scale. Is my patient critical, unstable, potentially unstable, or if my patient is stable. I will also determine if it's to load and go or to stay and play, given the presentation of my patient at this time. I also determine my GCS scale. Also, I will decide if I need to treat for shock or not. So at this time we load and go, I'll be moving on to the history taken. I will go to OPQRST for any pain the patient may be experiencing, onset of the pain, any provocation or palliation, anything makes the pain better or worse, the quality of the pain that the patient is feeling, is the pain radiating to anywhere, is it an isolated area, the severity of the pain on a scale of 1 to 10, 10 being the most pain the patient ever felt, and the time, how long ago the incident happened. I'll also do a sample history of my patient, the signs and symptoms. Does my patient have any allergies? Is my patient currently on any medications? Any past pertinent history? Does my patient suffer with anything? Any medical problems? Last oral intake, and the event leading up to the injury. Next thing I will do is move on to my secondary assessment, where I'll be doing a full physical examination of my patient, starting with the head. I will be looking for any tracheal deviation. My patient, decap BTLS, sorry, of my patient. Decap BTLS. Looking for any CSF in the airway or the nose. Tracheal deviation, jugular vein distension. Decap BTLS in the C-spine. Checking the trapezium for the decap BTLS around the acromion, around the clavicle, down to the chest, the sides. Checking back again. Decap BTLS. The arms, looking for decap BTLS. And the crepitus, my patient. Check the pelvic area for stability. I would press in and down, making sure the pelvic is stable. Go down the legs, looking for any decap BTLS. Decap BTLS. On the side. Next, what I'm going to do is take my patient's vitals, baseline vitals first, blood pressure, the pulse, respiratory rate. I will then go on to do an SpO2 on my patient, a DAS scan. I will check pupil to make sure there's no compromise to the brain. I would do auscultation of the lungs again. And I will do reevaluate the GCS of the patient. I will reevaluate my cups of the patient to see if my patient is deteriorating or improving, or still at the same impression that I had initially. And I would continue to reassess my patient if she is potentially unstable or unstable every 5 minutes. If my patient is stable, I will reassess every 15 minutes, starting back from the general impression to ABCs, history, and vital signs. Thank you.